Continuing our chapter on TB, let us see the lab diagnosis of tuberculosis. Diagnosis of active tuberculosis, specimen collection in pulmonary TB, sputum, 2 specimens, spot and early morning, gastric aspirate in children is taken. In EBTB, specimen vary depending on the site involved. Digestion, decontamination and concentration of the specimen by modified Petros method 4% NaOH and NaLC and L-acetine L-cysteine plus 2% NaOH. Direct microscopy can be done by acid-fast staining, Zn staining technique. Long, slender, beaded, less uniformly stained and red-colored acid-fast bacilli are seen. Canyon color acid-fast staining. Canyons, cold acid-fast staining. And fluorescent or auramine staining, more sensitive and smears can be screened more rapidly than Zn stain. Conventional culture media takes 6 to 8 weeks. Lowenstein Jensen medium shows rough, tough, and buff colored colonies in 6 to 8 weeks. Automated culture methods take 3 to 4 weeks. MGIT system detects growth as well as the resistance of anti-tubercular drugs (ATDs). Culture identification, automated identification by MALDI-TOF and MPT64 antigen detection by ICT. Molecular methods, PCR detecting IS6110 gene, CVNAT gene expert and TrueNAT for identification and detection of resistance to rifampicin has a turnaround time of 2 hours. Line probe assay, genotype TB for identification and detection of resistance to first and second line ATDs has a turnaround time of 2 to 3 days. Diagnosis of latent tuberculosis by tuberculin skin test, example Mantox test, and interferon gamma release assay or the IGRA. Lab diagnosis of active tuberculosis can be established by various methods as described below. The diagnosis of latent tuberculosis is explained later. Specimen collection in PTB, 2 sputum samples are recommended. Spot sample collected on the same day under the supervision and early morning sample collected on the next day. Alternatively, 2 spot samples at least 1 hour apart can be collected. Sputum collection booths should be located away from the other people outside in an open, well ventilated space as air dilutes the aerosol generated during the cough. Now, early morning sputum specimen should be collected in empty stomach after rinsing the mouth well so as to remove any food remnants as they interfere with smear examination. Inhale deeply. Patient should be advised to inhale deeply 2 to 3 times and cough out deep from the chest during exhalation and then to spit the sputum into the wide-mouthed screw-capped container. Quality sputum should be at least 3 to 5 ml in quantity, thick and purulent yellowish mucus. Salivary specimen that appear watery should be rejected. Extrapulmonary specimen vary depending on the site involved, which can be divided into 2 categories. Now, the digestion, decontamination, and concentration, sputum and specimen from the non-sterile sites subjected to smear microscopy and culture need prior treatment for digestion to liquefy the thick pus cell and homogenization. Decontamination to inhibit normal flora and concentration to increase the yield. However, this step is not required for molecular method and also for processing of the extrapulmonary specimen collected aseptically from sterile sites. Commonly used methods are modified Petros method or 4% NaOH sputum is mixed with 4% sodium hydroxide centrifuged and the sediment is neutralized with phosphate buffer saline. This method is recommended for algae culture. NaLC and acetyl L-cysteine 2 plus 2% NaOH. This is superior to Petros method for isolation. NaLC liquefies the sputum and NaOH kills the normal flora. This method is more compatible with automated culture systems. Okay, now sterile site specimens, the extrapulmonary specimen. Optimum specimen will be CSF, pericardial fluid, synovial fluid, and ascitic fluid. Suboptimal specimen, where organism load is less, will be pleural fluid and blood indicated only for disseminated TB and co-infected with HIV. Specimen for containing normal flora, swabs considered suboptimal specimen because the only recommended swabs are laryngeal swab collected early morning in empty stomach or swab from discharging sinus. Urine 3 early morning specimen collected 500 ml per specimen centrifuged on different days as TB bacilli in urine are shed intermittently. Stool for disseminated TB in HIV infected patients and infants. Other respiratory specimen bronchial secretion 2 to 5 ml, bronchoalveolar lavage 20 to 50 ml, and transbronchial and other biopsies collected in sterile normal saline. Gastric lavage recommended for children 10 to swallow sputum or ICU patients aspiration. Early morning lavage should be collected and processed early less than 4 hours. Note the samples for culture should never be collected in formalin. If histopathological examination is required, two samples should be collected. Now coming on to the direct microscopy by acid-fast staining, Zn staining MOT method. Smears are prepared from thick mucopurulent part of the sputum or with the sediment obtained after concentration. Optimum thickness of the smear can be assessed by placing the smear on printed matter. The print should be just readable through the smear. Then the smear is stained by acid-fast staining. Interpretation: negative result at least 100 oil immersion fields should be examined for 10 to 15 minutes before giving a negative report. Positive result: M. tuberculosis appears as long, slender, beaded, less uniformly stained red colored acid fast bacilli. Presumptive diagnosis: microscopy provides only presumptive diagnosis. If the typical beaded appearance is seen, then it should be reported as acid fast bacilli resembling M. tuberculosis are seen by smear microscopy by Zn stain. Advantages: smear microscopy is rapid, easy to perform at peripheral laboratories and is cheaper. Disadvantages: smear microscopy is less sensitive than culture, low sensitivity with a detection limit of 10,000 bacilli per ml of sputum. It cannot determine the viability of the bacilli. It is difficult to differentiate MTB from saprophytic mycobacteria present in tap water or even as common saline clinical samples such as gastric aspirate and urine. Now this figure shows the Zn staining of the sputum specimen showing long, slender and beaded red colored acid fast bacilli. Figure B shows auramine phenol staining of the sputum smear. Tubercle bacilli appear bright brilliant green against the dark background. Now this is the RNTCP guideline for grading of the Zn stained sputum smear. Number of the fields in 100 oil immersion fields. Okay, if 100 fields are screened and there is no MTP present, the grading is 0 and the result is negative. If 1 to 9 bacilli are present per 100 oil immersion fields and 100 such fields are screened, then the grading is referred to as scanty and we can also write the number of the bacilli seen and the result is positive. If 10 to 99 bacilli are present per 100 oil immersion fields and 100 such oil immersion fields are screened, then the grading is 1 plus and result is positive. If 1 to 10 bacilli are present per oil immersion field and 50 such fields are screened, then the grading is 2 plus and result is positive. And if more than 10 bacilli are present per oil immersion field and 20 such fields are screened, then the grading is 3 plus and the result is positive. Acid alcohol, 3% hydrochloric acid and 95% ethyl alcohol can be used to differentiate Mycobacterium tuberculosis acid and alcohol fast from Mycobacterium semigmatis only acid fast but not alcohol fast in the urine sample. RNTCP guidelines for grading of the sputum smear. Revised National Tuberculosis Control Program (RNTCP) of the India has given guidelines for grading of Zn stained sputum. Already we have discussed. RNTCP grading is useful for monitoring the treatment response of all the patients, assessing the severity of the disease, assessing the infectiousness of the patient. Higher the grade, more is the infectiousness. Smear negative patients less than 10,000 bacilli per ml of the sputum are less infectious. However, grading of the sputum smear depends upon the quality of the sputum collected as well. Quinine cold acid fast staining, it differs from Zn stain that heating is not required and the phenol concentration of carbofusion is increased. The duration of carbofusion staining is also more. Now the fluorescent staining is a fluorescent staining technique uses auramine phenol solution for 7 to 10 minutes as primary stain, 0.5% acid alcohol for 2 minutes twice as decolorizer and 0.1% potassium permanganate for 30 seconds as counter stain. Then the slide is examined under fluorescent LED microscope. The bacilli appear brilliant yellow against the dark background. Smears are screened by using 20x or 25x objective, hence can be screened faster to meant for 100 fields. It is more sensitive than Zn staining and has been the recommended screening method by RNDCP. However, artifacts may be confounded with the interpretation, hence the reading should be taken by an expert. Culture method. Culture is usually considered as the gold standard method for diagnosis of the TB. It offers several advantages. It is more sensitive than microscopy with the detection of limit of 10 to 100 viable bacilli and it indicates viability. TB bacilli growing on culture indicates that they are viable. Now coming to the drug susceptibility testing, it can be performed. RNTCP recommended culture media include both conventional solid media like the LJ Lowenstein Jensen medium and automated liquid culture such as Mycobacterium growth indicated tube MGIT. Conventional solid media, Lowenstein Jensen medium, LG medium has been the most widely used and recommended by RNTCP. It is composed of coagulated hens, eggs, mineral soil solution, asparagine and malachite green as a selective agent. Inoculated media are incubated for prolonged duration of 6 to 8 weeks. This is because of slow growing nature of tubercle bacilli. Now, the long generation time of 10 to 15 hours. Colonies. M. tuberculosis produces typical rough, tough, and buff colored colonies. In contrast, M. bovis produces smooth, moist, and white colored colonies that break up easily when touched. Conventional liquid media are Kirchner's medium and Middlebrook 7H9 medium. They are not routinely used. Automated liquid culture systems monitor the growth continuously and offer a faster turnaround time compared to the conventional culture. Positive growth 99% gets detected within 3 to 4 weeks. However, the negative result is reported after 6 weeks of incubation. They use liquid broth such as Middlebrook 7H9 medium supplemented with enriched growth media and antibiotic mixture to inhibit other organisms. Bactec MGIT Mycobacteria Growth Indicator Tube. This is the automated system endorsed by WHO and RNDCP. Uses it detects the growth of mycobacteria and also performs drug susceptibility testing against first line and second line anti-tubercular drugs. Principle: it uses oxygen sensitive fluorescent compound dissolved in the broth. Initially, the large amount of dissolved oxygen in the medium quenches emissions from the fluorescent compound. Later, actively respiring microorganisms consume the oxygen. The quenching effect is lost, which allows the fluorescence to be detected. Other automated systems include such as backtech and alert systems. Culture identification. The colonies grown on LG media and the broth from a positively flagged automated culture bottle are first subjected to acid fast stain. If found AFP positive, then the further tests are done for the species identification. MPT64 antigen detection by rapid immunochromatographic test. MPT64, a 28 Dalton antigen, is specific for M. tuberculosis complex, M. tuberculosis bovis and africanum, and negative for NTM non-tuberculous mycobacteria. Automated identification systems such as Maltitov can be used. Biochemical tests such as niacin test and rabbit pathogenicity test were used in the past, now they are obsolete. In these figures, we can see the culture media system for M. tuberculosis. A is the Lowenstein Jensen medium, B is Bactec MGIT, C is MGIT liquid culture medium, and D is gene expert system with cartridge. Okay, now serology. Serologic methods, both antigen and antibody detection methods, are not recommended because of the low sensitivity, cross reactivity with other mycobacteria, and variable antibody response against different epitopes. WHO has banned the use of serologic tests. Molecular methods. Molecular methods are extremely useful, such as they take less time than culture, they are more sensitive than culture. This is very much useful for extrapulmonary samples that are usually paucibacillary. They can also detect the genes encoding for drug resistance used for epidemiological typing of strains. There are several molecular methods available as described below. PCR polymerase chain reaction. Nested PCR IS6110 was the most common molecular test used earlier. Other genes which were targeted by using PCR MPT64 gene, 65 kilodalton and 38 kilodalton genes. Automated real-time PCR. With the advent of automated real-time PCR systems, the diagnosis of TB has been completely revolutionized. In addition, these systems can be used for diagnosis of other diseases such as COVID-19. Methods available are cartridge-based nucleic acid amplification test (CB-NAT), example GeneXpert, and chip-based real-time PCR, example TrueNAT. GeneXpert CB-NAT. GeneXpert Cephid is the CB-NAT system endorsed by WHO and is used in India under RNTCP. Rapid, has the lowest turnaround time, 2 hours, among all the diagnostic methods currently available for TB. Principle is based on real-time PCR technique, simultaneously detects MTB complex DNA and rifampicin resistance mutation of the RPOB gene. It uses 5 probes targeting various sequences of RPO-B gene. EPTB, WHO recommends Gene Expert as the initial test for diagnosis of EPTB, especially for CSF, lymph nodes, and other tissue specimens. As the bacilli are more in number in pleural wall, the ideal specimen for pleural TB is pleural biopsy, not pleural fluid. Diagnostic utility: the detection of the limit of Gene Expert is about 131 bacilli per ml of specimen. Compared to culture, and sensitivity and specificity are as follows. For detection of TB bacilli, it is 88% sensitive and 99% specific. For detection of rifampicin resistant, it is 95% sensitive and 98% specific. Disadvantage is very expensive, cannot further speciate the MTB complex. Next generation Gene Expert Ultra was endorsed by WHO in 2017. It contains two additional molecular targets to detect TB, IS6110 and IS1081. It is more sensitive and specific than Gene Expert with a detection limit of 16 bacilli per ml. Next is chip-based NAT. TrueNAT is a chip-based real-time PCR system validated recently by Indian Council of Medical Research (ICMR) in 2017, also endorsed by WHO in 2019. It is used in India under RNTCP. It has been developed by the Indian firm Molbio Diagnostics. Now, advantages: it is an automated battery operated device, can be used at level of primary health center where Gene Expert cannot be used as it needs uninterrupted power supply and air conditioning. The turnaround time is about 1 hour. Disadvantage is very expensive, cannot further speciate MTB complex and test only limited samples 1 to 4 at a time. Next, line probe assay LPA. Line probe assay involves probe-based detection of amplified DNA in the specimen. LPA in TB diagnostics has the following uses: detection of resistance to the first line anti-tubercular drugs ATDs, speciation of MTB complex in NTMs, and detection of resistance to second line ATDs. Limitation: LBA can be performed only on positive cultures or smear positive clinical specimens. It is not recommended for smear negative specimens as the sensitivity is low. LBA is useful particularly in isoniazid mono-resistant cases of TB which are not diagnosed by Gene Expert. RNTCP diagnostic algorithm. RNTCP recommended diagnostic algorithm should be followed for the diagnosis and further management of the tuberculosis. For pulmonary TB in adult, first sputum smear examination is performed. If smear positive, diagnosis is confirmed. If smear negative but chest X-ray is suggestive or presence of high clinical suspicion, CB-NAT is performed to confirm the diagnosis. For pediatric pulmonary TB, CB-NAT is directly performed, and for EPTB, specimens are paucibacillary, therefore CB-NAT is directly performed. If not available, liquid culture MGIT is performed. Diagnosis of latent tuberculosis. Latent tuberculosis is diagnosed by the demonstration of delayed or type 4 hypersensitivity reaction against the tubercle bacilli antigens. Two methods are available. First, tuberculin skin test, and second, interferon gamma release assay. Tuberculin skin test (TST). Traditionally, the tuberculin skin test has been in use for diagnosis of latent TB for more than 100 years. It was discovered by von Piquet in 1907. Antigens used: WHO recommends the preparation of purified protein derivative known as PPD23 for performing TST. Dosage: it is expressed in tuberculin unit TU. 1 TU is equal to 0.0002 mg of PPD. Okay, this was the diagnostic algorithm for pulmonary tuberculosis. Like, if a presumptive TB patient is there with PLHA, pediatric, EPTB presumptive or DRTB, then we can do direct CB-NAT. If there is only presumption, then smear examination or CXR can be done. Smear examination is if it yields positive regardless of CXR report. Smear is negative but CXR suggestive of TB, then we do CB-NAT. And smear and CXR either negative or not available with high clinical suspicion, then also we can do CB-NAT. Now, if MTB is detected, it can either be RIF sensitive, RIF intermediate, or RIF resistant. If not detected by CB-NAT or the result is not available, clinical suspicion, if it is high, then we can categorize it as clinically diagnosed TB. While if not, it can be something other, we can consider some alternate diagnosis. Now, if the smear was positive regardless of CXR report, it can be contained like microbiologically confirmed TB. If it is RIF sensitive, then also it is microbiologically confirmed TB. If RIF intermediate is there, repeat CB naught on second sample. If indeterminate on second sample, collect rest sample for liquid culture or LPA. If RIF resistant, then refer to management of RIF resistance. Now, all the presumptive TB cases should be offered HIV counseling and testing. However, diagnostic workup for TB must not be delayed. Now, not presumptive pulmonary TB refers to a person with any of the following: cough more than 2 weeks, fever more than 2 weeks, significant weight loss, hemoptysis, and abnormalities of the chest X-ray. Abbreviations used by RI for rifampicin. CB-NAT is cartridge-based nucleic acid amplification test. PLHA is people living with HIV or AIDS. DRTB are the drug-resistant tuberculosis. CXR is chest X-ray, and LPA is line probe assay. Now the procedure for the same Mantox test is most commonly employed method. 0.1 ml of PPT containing 1 TU is injected intradermally into flexure surface of the forearm in case of delayed hypersensitivity test of TB. Reading if it is taken after 48 to 72 hours at the site of inoculation and induration surrounded by erythema is produced. If the width of induration is more than equal to 10 mm, positive tuberculin reactors. 6 to 9 mm equivocal doubtful condition, and less than 5 mm it is a negative reaction. Interpretation of the result. Adults. Positive DST in adults only indicates present or past exposure with tubercle bacilli but does not confirm the presence of active stage of the disease. Hence, it is only used as an epidemiological marker. Prevalence of tuberculosis is calculated by counting all tuberculin reactors in a community. Incidence of tuberculosis is calculated by counting new converters to TST in a community. In children, a positive test indicates active infection and used as a diagnostic marker. False positive. The test becomes positive after BCG vaccination after 8 to 14 weeks. Non-tubercular mycobacteria infection. False negative. The test may become negative in various conditions such as early or advanced TB, biliary TB, decreased immunity, HIV infected people, etc. Interferon gamma release assay IGRA. This uses highly specific M tuberculosis antigens such as CFP10, culture filtrate protein, and ESA-T6, early secreted antigenic target 6, both coded by RD1 genes. Procedure. In contrast to TST, it is an in vitro test. Sensitized T lymphocytes collected from suspected individuals are exposed to ESA-T6 or CFP10 antigens, which lead to release of high level of interferon gamma from the T lymphocytes. An ELISA format is available commercially, quantiferon TB Gold assay. Advantage: it is highly specific, there are no false positive results. DST, the drug susceptibility testing. Several methods of DST are available which can be grouped into phenotypic and genotypic methods. Phenotypic, the MGIT used for first and second line drugs. Resistance is determined by the growth of TB bacilli in drug containing tube as compared to the control tube, which is drug free within 4 to 21 days of incubation. Proportion method is used for first and second line drugs, and isolate is considered resistant to a given drug when growth of 1% or more is observed in the drug containing LG medium compared to the control LG medium without drug after 42 days of incubation. Now, the genotypic method, GeneXpert, is used for the detection of resistance to rifampicin, targeting 5 different sequences of RPO-B gene. Turnaround time is less than 2 hours. Line probe assay detects the resistance to both first line and second line drugs with turnaround time of 2 to 3 days. UDST, Universal Drug Susceptibility Testing, UDST, refers to testing all TB patients for resistance to at least rifampicin by performing CB-NAT. UDST program has been rolled out across India since January 2018. So this completes our part 2 of tuberculous infections. In the next part we will be covering treatment part and the non-tubercular infections. Okay. So like and subscribe. Thanks for watching.